Dr. Johnathan Siegal is the Associate Director of the Emergency Room at NYPQ. Those of you who have been in emergency rooms and so on are very familiar with how they work. I have to tell you, in the last few years since he's been there and his boss, the place has become a very good place to go to. You really have to go. And he's going to tell us tonight what to do before you call Hatzalah, what to do before you go, and maybe how to avoid going there in the first place. Dr. Siegal.
Thank you, Dr. Brett. Welcome, everyone. So, quick introduction after that. My name is Johnathan Siegal. I'm an ER physician. I've worked at New York Hospital Queens, down New York Presbyterian Queens for about 12 years, believe it or not. Before that, I was from New York originally. I went to college at NYU. I had the pleasure of going to medical school in Israel at Sackler. Came back and did residency at NYHQ, NYPQ. And I stay here because I like the community. It's a very diverse and interesting community, very, I have to be thankful patient population, and it's really one of the best patient populations around. So, goal of tonight, two things. First, I'm going to go through some slides, and I can't tell you everything about when to go to the ER, right? Because there would be you'd have to go to medical school to learn that. But I'll tell you a couple of pointers, and then I'll open the floor to questions for you. And if you could ask me whatever you want. Why should I go? When should I go? How long will I wait? What do we do to prevent it? What to expect? I'm glad to answer anything that I can for you. Second part, switching topics, we're part of a major nationwide campaign now called Stop the Bleed. We are a trauma center in New York Presbyterian Queens, and part of being a trauma center, we're required to do community outreach. Last year or two, the community outreach nationwide has been Stop the Bleed. Last decade, it was CPR. Now it's Stop the Bleed. So we're going to go through some instruction, and then you can practice on mannequins. So what's
the microphone is not really reception.
Okay, thank you.
So it's not on.
Oh, it's not on. Is it on?
Yes. Yeah.
Okay. So Stop the Bleed is a nationwide campaign.
Much better.
Thank you. Where we are training the public what to do if you're in a situation with mass traumatic casualties in terms of stopping bleeding and using tourniquets and whatnot. So God forbid you ever have to do that, but if you do, then we have a campaign to teach the public how to do that. Okay, so the first part. When to come to the emergency department? Probably a question that a lot of people have and deliberate about before going. So, quick synopsis of New York Presbyterian Queens. It's a 535-bed hospital, which is large size, not tremendous, but large. The emergency department volume is tremendous. 123,000 patient visits a year, which is about 330 patient visits per day. It puts it in the top 5 of New York City, the top 15 in the United States. So believe it or not, our small hospital down the street from here is one of the biggest around in terms of the amount of people that go to the ER. The reason for that, there's been a lot of closures in the area. For those of you who've lived here a long time, you know that Parkway is gone, and LaGuardia changed, and St. John's is gone. So it's really consolidated the area into a couple of very large emergency departments, and the biggest one right around here is NYPQ.
Can those lights be turned off right here? I don't know how this works.
I don't know.
Anybody know?
Where does Jamaica Hospital stand by comparison?
Taking care of it.
Jamaica Hospital's annual volume is about 75, 80,000. Also big, but not as big. Okay. Is that better? Okay.
Thank you.
Okay, that's good. So, as I was mentioning, we have an incredibly diverse population around here, something we take pride in. 45% of our patients speak a language other than English. So, we use translators a lot, and you know, for those of you who live around here, you know how diverse it is in this area. Okay, that's a quick synopsis of the hospital. 330 patients a day. Level 1 trauma center, stroke center, cardiac center. We try to separate out pediatrics at the door, and we try to separate out low acuity urgent care visits at the door as well. This is all an effort to get patients to the area they'll be treated in as fast as possible and maintain a flow as best we can. So we're basically a center for everything that you can be a center of in a hospital. Can anyone think of some things that we wouldn't be a center of? You may not know this, but I try to ask some questions as we go along. Burn? Burn! Very good. There's one. And burn, and anything else?
Orthopedics.
Orthopedics we're a center of.
Deliveries?
Labor and delivery, big department. One of the biggest.
Hyperbaric?
Hyperbaric. We got a pretty educated audience here. There's
Poison?
And for snake bite, there's Jacoby. So except for a couple of very rare things, we're a center of what you can be a center of. Probably the biggest thing we don't have is the pediatrics ICU. So we're now more attached to Cornell and more Presbyterian Cornell. For those who don't know, New York Presbyterian is a very large hospital system. There's Cornell and Columbia and Queens are the three biggest hospitals in the system. We happen to not have a pediatric ICU, so if we have a very sick child that needs admission, we transfer them there. Basically everything else we keep in-house. So it's a large tertiary hospital that can do almost everything except for pediatric ICU, and as our very astute members here said, hyperbarics and burn.
You have a psychiatric floor?
We don't admit psychiatry, no. That would actually be another thing. We have a lot of patients in the ED, but if you need admission for psychiatry, they get transferred. Okay, so what do we do these days to ensure that the patient experience and the flow in the ER is good? These days, things are very, very data-driven. We have data to support all sorts of metrics and quality metrics and flow metrics and patient satisfaction goals. Just so the public knows what we do, our goals are to see every patient within 30 minutes of arrival. And we accomplished that. Our median door to doctor time in 2017 was 31 minutes, so we were 1 minute off. But maybe 3 or 4 years ago it was 80, 90 minutes. So if you ever go there, you'll see there's a PA in the front area, 15 hours a day, and you'll see somebody has got it within 30 minutes for the most part. We want all patients to be discharged within 3 hours. If you're going to be admitted, we want you to be upstairs within 6 hours. And this is tough. We want our patient experience scores to be 50th percentile or above. Hospitals these days are measured, and doctors individually are measured on lots of metrics. We tell all of our physicians individually what their scores were, how their speeds were. So in addition to making all the correct medical diagnoses, which is always your first job, you have to do it efficiently and with a good experience of the patient and whatnot. So while it can be a lot of pressure for physicians these days, it also creates hopefully a better environment for patients. And 50th percentile on national scale is very difficult. New York City ERs are extremely crowded, and it's also tends to be a tough crowd in New York City, so we do what we can. Okay, so I put a set slides on two or three topics that I just want to go through that I think people think about a lot of whether or not to go to the ER. And then again, I'll open the floor. You can ask me whatever you want of situations when you should or shouldn't go. But a big one is child bumps the head, right? They fall from a standing position, they cry, they might have a little cut, parents, late at night, parents deliberate whether or not to go. So there's a lot of data now that says when you should bring your child to your ED if they hit their head. Oh, I gave away the answer. So let's just go around the room. What would make someone want to bring a grandchild to the ED if they hit their head? When would you go and when would you not go? Laceration, I put it on already, right? So you want the laceration suit stitched, right? That's probably the first one that people think that needs stitches. I'm going, right? What else?
A bit dizzy.
If they're consistently dizzy afterwards. Dizzy, sure, okay, dizzy.
Headaches?
There's no wrong answers. I'm actually trying to learn myself what general public.
My husband just now said sleepy,
Sleepy, so
dozing off.
in medical words we say altered mental status, but yes, sleepy, lethargic, not acting as usual. Okay, so we got sleepy, we had dizzy, we had laceration.
Unconscious. Vomiting?
Persistently unconscious, sure, okay, and persistently vomiting. Okay, those fairly well-educated group. So what I put on there, what I thought was reasons the public would want to come. First, is there a laceration needs fixing? Is there a facial fracture? Are you concerned that the eye is in trouble? Are you concerned that they hit their head so hard that they have a brain injury? And do you just want to be reassured that everything's okay? We see a lot of new mothers and fathers, and they don't know what to do. The kid hits their head. They want to make sure everything's okay. So what age do you think is at the greatest risk?
Infants.
Small, right? Youngest.
Yeah.
Less than 2 years old. What area of the scalp do you think child falls, hits their head? What area has the lowest risk? What's the strongest part of your skull, do you think?
Forehead.
Forehead, okay, so, and that's probably the most common place you'll see a bump on a kid, and anybody's had a child, they fall forward, they try to protect themselves and they bump their forehead. So forehead bruises are not nearly as dangerous.
Crown.
What we
That's
call,
the worst.
behind the head, what we call the occiput, maybe right all the way back here, very bad. And we're sort of, the top, you know, if less than a year when they still have the fontanelles and they're not all fused, that would be a little more dangerous. But the most is behind the head, right? And if you think about it, we're not designed to fall into the back of our head. Most human beings turn themselves and fall forward rather than collapsing backwards and hitting right here, right? So a swelling in the front's not as bad. In the back, worse. The forehead being the least risky. Clinical signs that a head injury is severe, and we already had a couple. We had vomiting, that's one.
Eyes rolling.
Eyes rolling, we had eyes rolling, yes. Sleepy, we already had.
Slurred speech.
Okay. Talking about little children, but definitely slurred speech would be one, you know, depending on their age. Those are all good signs of what to watch out for to come to the ER. Persistent vomiting. We measure the loss of consciousness at greater or less than 5 seconds. Change in mental status, we said. Now, severe mechanism of injury. That's up to people to decide what that is, but if you fall from 10 feet, you're probably going to come to the ER. We're talking with these rules of basically fall from a standing position or fall off a piece of furniture or fall off a table or whatnot. A short table, I should say. Okay. So, PCARN, that letters there, is one of the largest evidence-based studies that has shaped emergency medicine in the last 20 years. It's a sample of about 30,000 children with head injuries to derive rules that we know who needs a CAT scan, who doesn't, who needs to be observed, and who doesn't. Well, one of the reasons I'm showing you this is just so you know the thought process behind when you do go to the ER. If the doctor decides this child's fine, they don't need a CAT scan, you can go home versus doing a CAT scan, there's usually a lot of evidence backing that up. And sometimes patients come to the hospital and they think, the doctor just told me to go home. And it's not, usually there's a lot of evidence to back up those decisions. So the reason I'm showing you this is just an example that's a very common cause that people come to the ER. So PCARN, basically, the evidence showed that if you are, an A is less than 2 years old and B is greater than 2 years old. And I'm not going to have you memorize this or anything. Yes?
You said CAT scan as opposed to an X-ray.
Okay, let me take one step back. If you hit your head and you want to tell if the brain is okay,
Yeah.
the only test that matters is the CAT scan. X-rays are for bones, broken bones, fractures. That's what X-rays do. CAT scans look at organs. Okay, so the decision tree for us with a child who hits their head is, are we going to do a CAT scan or are we not? The plus side of CAT scan is we know that there's no bleeding in the brain, which is really what we watch out for. The negative side is radiation. Okay, so CAT scan's the test that has the radiation. CAT scans are about 100 X-rays worth of radiation. In a small child's brain, in anyone's brain, but especially in a small child, they say that one CAT scan has a 1 in 2,000 chance of causing a lethal malignancy in their lifetime. Okay, so that's actually a lot. So if we did CAT scans 10 times a day on children, twice a year we'd be theoretically causing them to have a cancer at some point in their life. So it's really something to think about.
Thank you.
No problem. Basically, what this shows, and I'll just go to the next stage for the synopsis is, if they're, before the first birthday, they have a bruise only on the front, they have loss of consciousness less than 5 seconds, they're acting normal and it's not a severe mechanism, then you can watch them at home. You don't have to come. Okay?
So the bones are so soft then that that's so severe because of that?
Pretty much. I mean, children human being children can hit their heads. It happens all the time, right? We've grown like that. So the PCARN study of 30,000 patients showed that if you have these 4 things less than 2 years old, then there's basically no chance of a serious injury. So those are the 4. And that's what we do. If you come in, we go through this in our head or on an MD calc on the internet, and we say, okay, 1, 2, 3, 4. You have no chance of a serious head injury and go home, right? Yeah. Age 2 years old and above, actually, it's no loss of consciousness, no vomiting, no severe headache, no severe mechanism, and no altered mental status. So that's what we do if you're past your second birthday. Okay. Now, for many, many common complaints in emergency medicine, we have decision trees like this. I'm sharing this one with you because it's common and because it's one of the best evidence-based that we have, decision rules. Any questions on it? Okay, so if your child or grandchild, 2 and above, hits their head, they don't have these things, you don't have to come to the ER, right? And that's probably a very helpful thing for people not to have to come. Car accidents, right? Another big reason people come to the hospital. Okay? What would make you come to the hospital if you had a car accident versus not come to the hospital?
Blue.
Blue?
I like your bones or something.
If what was blue?
Like where your bone might be.
Okay, bruising, acute
No, like usually blue and like you can't move it or something.
Okay, well, like an extremity being blue? Or a bone would be?
Yeah, something like that, yeah.
Sure. Yeah. No wrong, that's a good answer. And I want to know what causes people to come, so please let me know. If you got in a car accident, what would make you decide whether or not to come?
Whiplash.
Whiplash, you would come, okay?
If you're hurt.
Pain?
You know.
Pain's a big one. Does it matter where the pain is, or just pain anywhere you would come? Would it,
And he goes away in 5 or 10 minutes.
if it goes away in 5 or 10 minutes, you wouldn't come. But if you had lower back pain versus abdominal pain versus pain in your extremity, would it make a difference? It doesn't matter.
I would be afraid of internal injuries.
Like internal bleeding is something that you.
That's what you're scared of, right? I mean, that's why. Right. Now, who here has gotten in a car accident in their life? Right? And did you go to the hospital when you had the car accident, or was it a fender bender where you didn't come?
Fender bender, that's all.
Fender bender, you don't come, right? So, just talking about it, what makes people come and what not to come.
Sometimes the EMT says you have to go.
Right. Okay, so EMTs, paramedics, wonderful people, very, very important jobs. I was one in college. I have the training for it. I was also the medical director of NYHQ ambulance before, so I have some idea of it. They are not really given the authority to say not to go. Okay? If asked, they'll default towards go. That's sort of what they have to do because they can't take the chance of saying don't go. So while I definitely value their opinion, and I interact with them a lot, they will tend towards saying go.
What about sometimes you might feel okay, and then later on you start to feel you have problems?
Good question.
I mean, does that happen often? I don't know.
All the time,
Okay.
right? I'm not saying it's an easy
So
decision for
then you
people.
yourself that you didn't go to the hospital right away.
That's what people deliberate with at home, right? What do? My back is starting to hurt.
Or your lawyer.
Okay, the lawyer too. I know people think that they need to build a record, medical record. So that's probably we don't ask why they came. We ask, came medically, but if they came because they want to build a medical record, I'll leave that alone because that's outside of the scope of what I can say and what I know. I know that the medical science. So okay.
But does that happen often that you might not feel it right away, but later on you feel it?
Yes. Okay. What I tell people is, it's like if you exercise a lot and you haven't exercised in a while. You'll feel okay afterwards, right? You ran 5 miles and you haven't exercised, but it's not that bad. Then the next morning you wake up, stiff, right? That's common. So car accidents are like that. You don't feel it right away. There's sort of the adrenaline in the moment. You get out, you're walking around, looking around, then a few hours later, oh my God, right? So those are all good answers, and I'll just go through some reasons why I thought people would come. Oh, why you should come. Okay. If you have difficulty breathing, definitely come. Then you're at risk of rib fractures, right? If you have difficulty walking, definitely come. You're at risk of fractures in your extremities. If you have severe abdominal pain, if you have altered mental status, if you're concerned that you broke a bone, I would come. If you think something's broken, come. But if you just have pain after a car accident, where you had a seatbelt on, you got out, you walked around, you didn't lose consciousness, now you're not having trouble breathing, but your back is achy, I don't think you have to come. Because that's standard. There's so much force involved in a motor vehicle accident, and motor vehicles are designed so well these days that the safety ratings are so much better than they used to be, that if you get in a car accident and you don't have those things, I think you're okay to take ibuprofen and see how it goes. So, of course, we in the emergency department, if you come, we're happy to see you, check you out, reassure you, do x-rays if needed, but I try to give you some ideas of when not to come. And that you should expect aching that develops gradually later, particularly in your back and your neck. And if you go to the ER, you may be frustrated that they didn't do very much if that's all you have. They may say, you may wait because you're below acuity, and then you may get ibuprofen and say follow-up. Question?
If you wear a seatbelt, and even if the bag is not inflated,
Right.
how would you have severe abdominal pain? You're not in contact with any part of the car.
Then you shouldn't have severe abdominal pain, right? And you shouldn't have to come. I say severe abdominal pain because if you have a high-speed accident where there's intrusion of parts of the vehicle into the car, it's collapsed inside and crushes into your abdomen, then you're at risk of severe bleeding, right? Or if the accident was so fast that you were thrust against the lap belt, that could cause internal bleeding as well. So abdominal pain is actually something we take very seriously after a motor vehicle accident, whereas lower back pain is something we don't take as seriously. And that's why I put it on there. Because lower back pain is not usually a sign of internal bleeding, whereas abdominal pain is. Okay. And the sixth one, pedestrian hit by a car. Now, I put that in a completely different category than motor vehicle accident. Anyone who's hit by a car, we're extremely careful with. We're extremely careful with anyone. When a pedestrian hit by a car, we're very, very careful with because of the mechanism. If a human being is hit by a 2,000, 3,000, 4,000 pound vehicle, it's very, very common that they have fractures and injuries and whatnot. It's a very bad thing. One of the biggest pieces of advice I tell people is be careful walking, right? Be careful driving, wear your seatbelt, but be even more careful walking because the fatalities and the bad injuries, especially here in New York City and Queens, is pedestrians. Okay, so if you get hit by a car, seek medical care, and don't get hit by a car. That's my 2 pieces of advice. Okay. Expect the following after motor vehicle accident. Gradually, you'll develop aching in your lower back and neck. Stay hydrated, okay, because the inflammatory process after an incident does better if you're hydrated, okay? Stretch yourself. If you have back pain after a motor vehicle accident, you don't want to just lay in bed or stay motionless. You want to move yourself as soon as you can afterwards during recovery. You know, the next day or two, try to touch your toes. Try to keep yourself a little bit limber. Don't think that you have to not move if you have minor pain after a car accident. And if you have symptoms that last more than a couple weeks, that's when you follow up and you get further testing. Now, I said X-rays are for fractures, right? And CAT scans are for organs. If you have something like a slipped disc or a ligament tear, these are longer term things that are harder to find out, and you would follow up with an MRI as a test for those. Now the ER will not do the MRI. The MRI is done if you have continued pain for a while afterwards, you get an MRI. Questions about motor vehicle accidents? Okay. The final section, before we just go to general questions, then on to stop the bleed, is antibiotics. This is a big one for people also. They go to the doctor, they don't get antibiotics, they're upset, the doctor didn't do anything, he didn't give me antibiotics, right? Now there's some conditions which antibiotics help, and there's some conditions they don't help. And antibiotics have side effects, right? So if the doctor does not give you antibiotics, they're not just that they don't want to, or that they don't want to make you happy, that should be a logic behind why they didn't give you antibiotics. So what do antibiotics kill?
Bacteria.
Bacteria, good. Okay, great. You got in unison too. So antibiotics kill bacteria. They don't kill viruses, right? Okay.
Not for colds.
Not for cold. That's one of the questions.
I don't think they kill
You guys are
protozoas
too
either.
good. What's
I
that?
don't think they kill protozoas either.
They don't kill protozoas. There's different agents that kill protozoas. You're right.
Malaria is protozoa, I think.
Malaria's protozoa? Yeah.
I think so.
Yeah, it is. But, you know, protozoa I'll put sort of in the category of bacteria because they're bigger unicellular creatures that there's different antibacterial agents that also kill them. Not bacteria, there's antibiotics that kill protozoa. You're right that they're different than bacteria, but They're sort of treated the same with antibiotics. Urinary tract infection. Do antibiotics help? Or do they use for, do you treat a urinary tract infection with antibiotics?
Yes.
Yes. Okay, good. Urinary tract infections typically are caused by bacteria, okay? And for anyone who's ever had one, they know that antibiotics are very helpful. So, yes, that's something that you should be treated with antibiotics for. Yes. Influenza.
No.
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 No, influenza is a virus, right? Okay, good. Now, there are antiviral agents now that are used for influenza. The efficacy of them is not nearly as great as antibiotics are for bacteria, but there's Tamiflu now. So there is an agent for influenza in particular. I'll leave that as a separate category. No. Bronchitis. Yes, no, depends.
Depends.
Mm.
So classic, I'm going to say no. Classic bronchitis is caused by a virus, okay? And it's not treated with antibiotics. Now some doctors will give you a Z-Pak or Zithromax for bronchitis, sort of cover themselves just in case they're missing atypical pneumonia. But just to categorize in your brain, bronchitis is not something that's treated with antibiotics. Or has to be treated with antibiotics, I should say. Pneumonia. Yes, pneumonia is treated with antibiotics. Now, the difference between bronchitis and pneumonia.
Bronchitis is in the bronchioles, pneumonia is in the lungs.
True, the bronchioles are part of the lungs, right?
Right. But it's like fluid, pneumonia fluid in the lungs?
You got it, right. So pneumonia is when you get an actual collection of fluid or mucus clogging up a portion of the lung. Whereas bronchitis is an inflammation of the linings of the lungs, right? So if there's a collection of fluid in the lungs that the doctor can hear with a stethoscope and see on the chest x-ray, then antibiotics are definitely indicated. Yes?
It might depend though on the patient, like, I have a friend, he's 93, almost 93, and recently had a bad cold. And his doctor put him on a regimen of antibiotics. So, put him with his daughter, so we were texting back and forth. It's not for a cold, I said. Because you told me the doctor said, because he's 93 almost, he was concerned that the bad cold might make him susceptible to something else.
Mm-hmm.
So because of that, he put him on the
Okay.
antibiotics.
Fair enough.
So it
And
depends.
I'm not here to second guess that doctor's opinion or on a situation. I will say that generally, we think that antibiotics are overused, that patients who come to doctors want antibiotics and sometimes are upset that they don't get them, and that the evidence-based medicine shows that for a common cold, that antibiotics are not helpful. And I'll leave it at that. Now, if it's more complicated, you're concerned that it may be pneumonia, he's got a lot of risk factors, then you may just cover yourself and give them antibiotics anyway.
It's preventative, just in
Preventative
case.
just in case.
Because of the cold.
But I'm not sure that that's evidence-based. We try to do everything evidence-based now, not just an opinion, but is there data showing that for this condition it works, right? And I will not say that antibiotics are useful in a common cold. That's not proven. Okay, it's proven for for urinary tract infection and pneumonia. It's not proven for common cold, despite the fact some doctors may do it. So if you go to the ER and you're not given antibiotics for one of these conditions, I want you to understand why. Because what I'm sort of getting at. Now the practice is maybe to give antibiotics in situations that they're not necessarily necessary for.
Thank you.
No problem. The common cold, no, right?
No.
Okay, sepsis. Does anyone know what sepsis is?
Yeah,
Infection.
Blood poisoning.
it's when the,
Blood poisoning?
it's
That's
when
good.
the body shuts down the different systems,
Good.
slowly but surely.
It's an infection.
It's an infection. It's a blood toxin. The way I'll say it is, it's when you have an infection that's so severe that it causes your whole system to become affected by it, where your blood pressure starts to lower, where your heart rate starts to get very fast, where you start to have difficulty breathing, where your blood can become acidotic, and where you get very sick and can die, right? So
collapse,
sepsis is when an infection starts overwhelming your system and causing toxins to enter your blood because of the amount of infection you have, right? So for sepsis, are antibiotics indicated? Yes, right. So definitely, it doesn't matter where the infection started. If you get sepsis and have the signs of sepsis, which we watch out for, which is low blood pressure. We measure something called lactic acid in your blood if it's high. There's numerous things we do to check, but you'll be hospitalized and you'll be put on antibiotics. So if your loved one are in the hospital and there's called sepsis, and you see that you will see them on antibiotics, and they will be indicated. Yes.
How do you determine which antibiotic you should use for each of those conditions?
It's a good question. We start off, for sepsis, we start with broad spectrum antibiotics. Until we can figure out exactly what's causing it, we give antibiotics that kill all sorts of bacteria. We usually give a combination of 2 or 3 different ones to make sure. For other ones, there's more typical bacteria that cause urinary tract infection than that cause pneumonia. So there's antibiotics that are typically given for a community-acquired urinary infection versus pneumonia. Now, in addition to that, we send off a culture, right? So if you get treated with a urinary tract infection, we do a culture that 2 days later tells us what exact bacteria, antibiotic the bacteria is susceptible to. And then we may change the antibiotics at day 2. So the quick answer is we guess based on the condition you have what antibiotics you need. And the longer answer is after a day or 2 we do cultures and have a more specific answer.
So it's guesswork too.
It's guesswork too, yes. Yeah. Okay. Infant less than 1 month with a fever. Hospital and back antibiotics no matter what, even if we think it's a virus. And the reason, so yes, doesn't matter. Less than a month, really less than 6 weeks, any infant, febrile, fever, go to the hospital. Why? Their immune system is not developed yet. The maternal antibodies are still there, but they're leaving and they don't have their own antibodies yet. It's the highest risk period by far in a child's life, the first month to 6 weeks. If they have a fever, they're staying in the hospital. They're getting antibiotics. And you're waiting until cultures come back and they're observed to make sure they're okay. And the reason for that is very evidence-based. The risk of the 2-week-old with a fever getting sepsis and possibly having a very bad outcome is much, much, much higher than after 2 months of life, let's say. Child over a year with runny nose, cough, and fever. Antibiotics or no antibiotics? No. Right. Okay. Now this is a discussion I've had, and when I do pediatric ER shifts, about 10 times a shift. Why am I not giving antibiotics? Because it's a virus. So you all seem very actually educated on the subject, which is enlightening. So, but there's generally no indication for antibiotics in children who are well-appearing, over a year old, with symptoms of a common cold. They should be given maybe Tylenol or Motrin if their fever is above 101 or 102, but otherwise allowed to sleep, let their immune system work, and be given enough fluids and time to rest to recover. Very good. No. What are some common side effects of antibiotics? So if you take antibiotics and you don't need to, even if you need to, but what happens if you take antibiotics?
Allergy reaction.
Allergic reaction can happen, yes.
Diarrhea.
Diarrhea can happen.
It was a good bacteria.
Because it kills the good bacteria. Very
It
good.
kills good bacteria too.
It kills the good bacteria too, yes. So abdominal cramps, diarrhea, nausea. I left the allergy part out, but that's true also. So we're learning more about how to handle this these days. You should take actually probiotics, they're called, if you are given antibiotics. That's a powder that has active cultures like there are in yogurt that help restore the normal flora or bacteria that's in your intestine that helps you digest. The problem if you take antibiotics is that it kills all the bacteria, the good, the bad, and if you kill the good, then you can't digest well, and you get diarrhea. Yes?
They're advertising currently, like a new type, which is like a heavy-duty one. Is there a danger to taking one which is too strong?
A probiotic or a...
Yes.
I haven't heard that there is. So
Okay.
I never heard that there is. I can't say that there's not, but I've not heard that there is. The usual one that we prescribe is Floristor, it's called. And even if you don't do that, then we advise people to eat yogurt, actually, believe it or not, probiotic.
Fermented foods, sauerkraut,
Fermented food, sauerkraut, whatnot, yes.
pickles and something.
Pickles and things like that, yeah. Okay. So I just wanted to go through a couple of categories of things that people come to the ER for and answer questions when to come, when not to come, what to expect. Is there any further questions? I'm glad to answer anything about the ER, when to come, when not to come. Yes?
All right. As a patient, as a possible patient,
Yes?
you feel you may be getting a stroke. You feel
Okay.
something doesn't work, or you feel, or you have pain, you think it's a heart attack.
Yes?
You have to decide, you have a choice. You don't have to rely always on somebody else, which hospital to go to. You give some statistics how long you have to wait.
Right.
Based on what I remember seeing in emergency rooms,
Right.
it's not the way it looks.
Right.
For example, how many cubicles does Booth Memorial have in the emergency room? How many beds?
70-something beds, and then patients get put in the hallways also when it gets crowded.
Not counting the hallway.
75, I want to say.
75?
Yes.
75 cubicles?
If you've been there, patients are, there's curtains separating patients from each other, so I'll call that a cubicle, is one section between curtains. And there's about 75 of those, in addition to 5 or 6 rooms that are more like closed off rooms that are for the sickest patients. For those of you who've been there, it's, in the wintertime especially, it's extremely crowded. It's a problem. I'm not, you know. The physical crowding of ERs at our hospital, Booth, New York Presbyterian, Queens, is a problem. So we try to have the best medical care and have you seen fast despite the crowding, but you know. If you're thinking about a stroke or a heart attack, I will say that if you come with symptoms of a stroke that are less than 6 hours duration, you'll be rushed in. Okay, you'll be seen right away. If you come with chest pain, you'll be rushed in. We have to do an EKG within 10 minutes if you have chest pain. If you have stroke symptoms less than 6 hours, then you have to have a CAT scan within 25 minutes of arrival. There's all sorts of goals and metrics that we pretty much accomplish with those things. The problem is if after the CAT scan it shows that you don't have a stroke, but you just need to stay for observation, that sometimes during the flu season in the winter you spend 12 hours waiting in a not very comfortable situation, waiting afterwards. Did that answer your question?
12 hours.
Any other question?
Which days are the busiest?
Monday.
Monday?
Monday, yeah. Monday and
Not
Tuesday.
Friday, Saturday?
No. Monday's the busiest day by about 15 patients per day. The busiest day in pediatric is Sunday.
12 hours waiting for what?
If they decide to admit you, at our worst times, the time from when you get there till you go upstairs to a bed, the median is 12 hours. That's in January of this year during this flu season was bad,
I
right?
thought you
So
were like at 6 hours.
that's our goal.
Well, those are the goals.
And that's what happens, to be honest, in the 6 months a year, it's 6 hours. It's 8 months a year, it's 6 hours. In December, January, and February, it becomes a very big challenge. And sometimes people wait longer, quite often. Yes?
Yeah, once I remember my son was about 4 years old, he had a fever. We went to the hospital. There must have been like 30, 40 kids ahead of him.
Yes.
And I said, I'm not waiting here for 4 hours and they're gonna look at him for 2 minutes. Unless it gets really bad, we'll come back, and I took him home. Did I do the right thing?
How's your son doing now? I think you did.
He was okay after that.
That's one of my goals of being here, to show you the couple of pediatric issues that are common and when to come and when not to come, you know? Because the doctor will, if it's, let's say it's the head injury, and he goes to the mental checklist in 30 seconds, you'll wait 4 hours, you'll be seen for 30 seconds, and told to go home, you know?
Right. That's what
There's science behind
he
it.
was just running a
there's-
he was running a fever, but
Yeah.
there must have been some bug going around that night.
Yeah. It's possible to wait and then be told, and be seen for 2 minutes and told to go home.
Why is Sunday the busiest day for pediatrics? Because daddy's home to watch the other kids.
That's cute.
I understand it's frustrating when that happens. I was trying to show that there's a science behind it, but you know.
What the fungal infections, how can be treated?
fungal infections,
Yes.
there's specific antifungal agents.
What,
There's antifungal medications. Now, if we talk about foot, toes, nails fungus, that's usually treated with a cream. If you have a far worse condition, you have fungus affecting your whole body and you become septic from it, then you get them in the IV. The fungal infections actually are fairly rare to cause severe symptoms in people. The most common groups that get severe fungal infections are immunocompromised patients, meaning patients who have a worsened immune system, HIV, lymphoma, leukemia, chemotherapy. Those patients have much more risk of fungal infection. Yes.
One of the things about the ER that kind of like disturbs me, if I'm afraid to go sometimes or anything
Yes.
else. This is New York City here,
Yes.
and not everyone is such a high class of a person, if you know what I mean. You
Yes.
might find homeless people, gangs. I don't want to be in an ER with a gang who just got shot.
Yes.
No, I'm serious. It's not.
I know.
Or a homeless guy. You don't know. What disease he's full of. It might be more dangerous to go in there than it is.
Okay. I don't know if there's a specific danger from being in the ER. I've never heard of another patient being injured by a gang member or a homeless person or something like that. But the ER is the safety net of the healthcare system, right? And being that, you will have all classes of people there. You'll have homeless. You'll have basically everybody. So, in New York City, these days you don't see very often a completely intoxicated homeless person laying on the sidewalk that looks like they're very sick anymore, because they take them to the ER. So that's the trade-off, is that our ER see everybody and make sure they're okay. And the negative is that if you go there, you'll see all sorts of people.
Do more of them go to Queens or do they go to Booth?
Yeah, I don't want to go too far much more into it. We see everybody who comes regardless, and other patients are safe, in the ER. Yes.
Do you have a dental department?
Yes. We have a dental emergency department. It's one of the few hospitals that has it. And there's a dental residency there, and they're available 24 hours.
Director was here last
You were there?
I was there once.
You were there once?
Yeah.
Okay.
do the physicians rotate between Presbyterian, Manhattan, or other areas?
They can. We generally don't. Most of us work full-time at New York Presbyterian Queens. A lot of us do shifts other places for moonlighting or overtime and things like that. But it's generally better to know one hospital and be good at that than constantly moving. So we're very connected to the New York Presbyterian in Manhattan in terms of our guidelines and committees and electronic order sets and things like that. I'm on conference calls all the time between us and Cornell and Columbia to try to form best practices between the hospitals to use good ideas that each hospital has to improve the hospital, but the physicians themselves usually just work at one.
I have a couple of questions.
Dr. Bright.
I want to
Yeah.
ask the audience. First of all, I'm going to tell a story, about emergency rooms. This is a true story that happened today. I saw a lady yesterday who fractured her radius, her forearm bone, and she went to Long Island Jewish's emergency room, and she was casted, and she was told to call a certain orthopedic group for follow-up care. I saw her yesterday, and she was in terrible pain because the cast was too tight, her fingers were swollen. And they said, you've got to go to the orthopedist that they referred you to. She called me today very upset, saying she called them, referred to them by the ER, and the office said, I'm sorry, we don't take your insurance. That is not going to happen at NYPQ. It's a fact. I blew my mind. I was so upset. Okay, 2 questions that I'm going to ask you. You have a diabetic who's insulin dependent at home, and he starts getting dizzy. What do you do? Anybody?
Give him candy.
My husband said feed him.
Some juice, milk, or candy.
Feed them what?
Orange,
Get them something
a
sweet.
sugar
real fast.
sucking candy.
Right.
Milk.
Do not call Hatzalah and ask them what to do. Do not take him to the ER or her to the ER. Secondly, somebody at home, particularly an older person, begins to act funny and you call up, you don't know what to do. What is the first thing you do when somebody at home starts to act funny who's elderly? Say that again?
He said turn off the TV.
No, seriously. What do I tell people to do under the circumstances?
Get them to lie down.
No.
No.
Take their temperature, okay? Very frequently, elderly people particularly will get confused when they get a fever. If they have, what do you do if they have weakness on one side or slurred speech?
Slur speech.
Get them to the hospital right away, to a stroke center. Now, we had Dr. Bernardini here last year, those of you here, learned
Right.
that we really can do a lot of things for early strokes. And it's very important that you get
First 2
people
hours.
to the ER as quickly as possible.
Right.
Okay, heart attacks, that, everybody knows that one.